Patient was in the ICU, couldn't speak, and it was very clear that they were dying. But the spouse came and said, I can't tell my in-laws. I can't tell our kids. I can't be the one. If the story is years from now, that horrible view of a doctor, fine, they'll never see me again. When you know you're following someone's wishes, that is a gift. That is a huge gift that you're giving to your family.
Welcome back to Kicking Cancer's Ass, the podcast rewriting the cancer story to put you in control. I'm Joelle Kaufman, and today we're talking with a doctor most patients never have heard of, but
Yeah.
often ends up holding the most delicate, sensitive conversation of your life. I'm so thrilled to bring on my new friend, Dr. Monique Nugent. She's a hospitalist. She's the author of Prescription for Admission. We'll put a link in the show notes. And she's a host of the podcast, Prescription for Admission. And in a first for Kicking Cancer's Ass, we're going to do a concurrent release. So on Kicking Cancer's Ass, you'll get to know Monique. And if you want to hear what Monique wanted to learn from me, we did that over on Prescription for Admission. So
Yeah.
Monique, it is awesome to have you here.
Joelle, thank you so much for having me here. And yes, it's the first for Prescription for Admission as well to have episodes together because I feel like both messages are so important to both audiences. So thank you for letting me spend some time with your listeners.
And thank you as well. So I do think it's really interesting to go to Prescription for Admission, and you have such a different perspective because you're coming at this from a context, especially in America, we never talk about death and dying, and the last place anyone wants to be is in a hospital.
Yeah.
And, you know, then you end up there for some reason, and they meet a parade of doctors. It's like an endless parade of specialists and people. And tell me a little bit, tell everyone what you do
Yeah.
and why families end up turning to you.
Hey, it's Joelle. Before we get deeper into the episode, click the subscribe button and be part of our growing community of people committed to ensuring everyone can kick cancer's ass in whatever way. And you would help me a ton if you'd leave a review or a comment. If you're on Spotify, please give me 5 stars. If you're on Apple Podcasts, 5 stars and write something. If you're on YouTube, please give it a thumbs up and write a comment. This helps so much. And if you want more Kicking Cancer's Ass, you want the in-depth analyses and articles and resources, go over to kcapodcast.com, take a look. You can subscribe for free, or you can become a paid subscriber and get the really meaty, good stuff every week. Thank you for being here. Let's get back to the episode.
So you started off very much on point. I am the type of physician that most people haven't heard of because you don't get to choose to see me. I am a hospitalist. I practice what is called hospital medicine, meaning I only see patients in the hospital. My entire practice, my entire specialty is that time in your life when you're sick, in pain, and things are moving fast. And we have come to understand medically that the hospitalized patient is a very unique patient with a lot of really unique risk factors, with a lot of really unique needs. And so that's why it's a specialty within itself, right? We do hospital-based research. There's economic issues that go into hospital care, right? So the things that happen in a hospital stay, and the average hospital stay in this country is about 5 days. There are people who are there shorter, there are people who are there longer, but 5 days of intensity, 5 days that will change things, 5 days where you're seeking questions, getting answers that you expected or didn't expect. And like you said, meeting a parade of doctors and getting a plan for what's going to happen day 6, day 7, day 8, day 22, right? And so, as a board certified internist who has decided to build her career in the hospital as a hospitalist, for me, it's this really unique and honorable experience to be in people's lives when they literally need you the most, right? And it is something that I cherish, but it's also something that like You don't get to choose. So you've never heard of it. You're not perusing to see who's the best hospitalist because it doesn't matter who you pick. They may not be there. They may not be up for an admission, you know. And so it's really about making sure that you can go into a hospital and know that this is the person who's going to catch me, who's going to put all my care together and can be the touch point for every question I have. If they don't have the answers, it's their responsibility to get it. But it's also their responsibility to help me with the next steps. And that's what makes the big difference is planning for the next steps.
So, I think we talked about my family just went through a surprise pair of visits in a hospital, not cancer related, but related to MRSA.
Mm,
And the need to have a professional who can interpret
yeah,
and reconcile all the things that are happening and ensure that all the different specialties are doing what they need to do when they need to do it. And you're informed because, it's your body or someone you love, but we're not medical experts.
right.
And there's a lot of terminology. I remember, this is probably going to make you laugh. Um, because my dad was in pain, he was on his back.
Yeah.
Well, after about a few days of that, the pulmonologist comes in and says, "You have to sit up. You have to walk." And he's like, "I'm in pain." He's like, "If you don't sit up, you're going to get pneumonia."
Well, yeah, yeah.
And he's like, "I'm in pain." And I paused it there and said, "Let me make sure we understood this right. If he continues laying down, he will get pneumonia." And they said, "Yes." I said, "Definitively." He said, "Yes." And I looked at him and I said, "Well, but" right?
Getting up.
You're right, like, "Looks like we gotta find a way to get you up." But
Yeah.
it there we needed the coordinator, and someone needed to be saying, I think, someone like you, "Hey, this guy's been flat on his back for X number of days. We gotta get PT in here. We gotta get other people in here to get him upright."
Yeah. And a
So
lot of it is systems, so understanding who is responsible for that, how often like, that may be an order that I have put in, up out of bed, you know, uh, people think that it's silly for that I write these things, but I write these things out of bed for meals, right? So that I know you have gotten up, you've been mobilized. And it is about the system, it's about communication, it's about expectations. And then what you said, he was in pain. If his pain's not addressed, he's not gonna walk. So it's about symptom management, and specialists will come in and have lots of things to say, but it's up to the hospitalist to be that touch point to put it all together.
well, and then we put it into the cancer arena because cancer patients end up in hospitals and see people like you. And now we're talking about complex drug interactions. We're
Mhm.
talking about a team, an extended team, and choices that are should we stop? Should we keep going? Should we do less? And
Yeah.
you were telling me, Monique, people bring that up with you. Can you tell us a little bit more about
Yeah.
that? Because, cancer world is the worst amusement park on the planet, but,
Mm.
the caricature is you have to be a warrior. You have to keep fighting. And I think you've seen some other things.
Yeah, it's what you said about the language, the expectations, the journey. I am oftentimes like a stranger, whereas the journey for a cancer patient is very intimate. Right? It's not just intimate relationships with your family and your friends who are going through this with you, who have been on the journey, who have their own expectations about how you're going to do, their own hopes about you getting better. But you have this intimate relationship with your specialist, with your oncologist, with your radiation oncologist, with your surgeon, right? And here comes this interloper. I don't know you, but I'm seeing you when you've got a fever, when you're in pain, when you can't breathe, when things are scary. Or I'm seeing you when things have been kind of going down slowly and people are questioning. And I get to be in this really unique position professionally with patients, but also with my colleagues. I've had a lot of conversations with oncologists to say, hey, your patient's been in the hospital a bunch of times. Let's look at this prognosis. Where are we really going? Have you had these conversations with them? Because I'm having these conversations with them. And as hospitalists, it's kind of like one of our little jokes that the oncologist isn't going to have an end of life conversation. It's going to be the hospitalist. Um, and it really does depend on how comfortable people are with being honest with everyone on their journey all the time. Because what I find is sometimes people take solace in the interloper. That like I come in and they're like, I don't know you from Adam, but I'm gonna tell you everything,
Well, I think it's
and
because, Monique, they're not gonna disappoint you, and they don't care about your feelings because 'cause they're not invested in you. And
yeah.
so, in a lot of ways, like, all these filters come in. It's like when cancer patients don't tell their doctor about all the side effects or that, they
Mhm.
can't move for multiple days because they're so fatigued, but they don't want the doctor to be disappointed, or they don't
Disappointed.
want the doctor to say, "Stop the treatment," because they think that means they're gonna die. And so
Yeah.
there's this other psychological dynamic. You show up, and it's like, and by the way, I may see you once because you may not be on my service
The
the
next
next
day.
day.
Yeah. There is studies have shown that there is something in the intimacy that does lead to the difficulty with conversations and expectations, and that hospitalists do have that opportunity to come in and kind of break cycles. And it goes both ways. I have had a lot of patients say to me, "I can't tell my kids. I can't tell my husband. Can you do this for me?" And I've also gone back to my colleagues in oncology and say, "Hey, you're not seeing what I'm seeing. Let's sit down and go over this again because your patient is suffering. Your patient doesn't want to disappoint you. This is the situation. Let's have a conversation about your expectations for the patient." And it is an honor to be able to do that for people. But like you said, it's that expectations. We all have expectations for everyone in our life, and everyone has expectations for us. And how hard is it for a parent to say to their child, be it an adult child, a teenager, whoever, but like, I cannot do this anymore. Um, Financially, when I used to be a resident and work in the VA hospital, there's a lot of financial implications when someone is 100% service connected and maybe getting different payments. And they may feel like financially, I have to hold on for my family. Right. So there's all these expectations, and I get to kind of break the cycle.
So, can you tell us a little bit, like, a story about that and how the family responded and how it kinda worked out?
One of the first times it hit me really hard that this was something someone was asking me to do. It was not the patient themselves, it was their spouse. The patient was in the ICU, couldn't speak because they were on a ventilator and extremely ill. And it was very clear that they were dying. But the spouse came and said, I can't tell my in laws. I can't tell our kids. I can't be the one. And it was like, oh, okay, I can be that for you. Right. Because you have to exist in this after this. If the story is years from now, that horrible bee of a doctor, Dr. Nugent was the one who said that, my mom was going to die in the ICU and X, Y, and Z. If that's the story and the lore that that family member needs to carry to get through, it's fine. They'll never see me again. But this man was watching his wife suffer and was like, I can't do this, but I also can't do this part. And I was a fairly young physician. I was like a senior resident, and that was the first time it really hit me that like, wow, I'm being asked to carry a burden and play a role for someone because they can't do it now, and this is another part of my doctorly duties.
Does your residency did you get any training, like chaplaincy or
I
anything
will
about
say
how to
this.
do this?
Loma Linda University Medical Center is where I did residency, and they are really focused on whole person care. And we spent a lot of time with palliative care. And we also had this really unique experience. He has since passed, but he was one of the chaplains who would do whole person care rounds once a week with residents. And you would get to sit with the chaplain and, see what he was going through and how he spoke. And so I did get a lot more, I think, experience than other residents did because of the values of Loma Linda.
Mhm.
But you are 100% right. It is a skill. It needs to be taught. It needs to be revisited. It needs to be updated. You need to go to conferences. I have a a mentor, Dr. Gina Moore, who's a wonderful palliative care physician, and she says, "Just because you can say words doesn't mean you can say words to people."
So true.
And it's
So
like,
very true.
you are right. So, like, she's like, "Spend some time with me to learn how to put the sentences together, to learn," and it is recognizing the weight of your words and humanity in others, and that takes training. It does.
So, Monique, one of the interesting things I've been asked is how my professional career and my cancer experience and my cancer advocacy overlap. And one of the things was trained in, was about process communication.
Mm,
And a core tenet is that we all communicate the way we want to be communicated with.
mhm.
And under stress, it is completely predictable how we will escalate based on how we show stress. And that signal also says how to communicate with someone.
Interesting.
So it's this concept, but it's not just knowing the words. It's first knowing, oh, that husband whose wife is too young to die. He's got
Mhm.
kids and he's got in laws, which means his wife is in the middle of life, not at
Yeah.
the end. And everything about this is wrong. And he's stressed. And the first thing we have to do in any form of stress is address the stress.
Mhm.
Because if you just start talking about the choices, he can't hear you. It's like peanuts. Wah, wah,
Yes.
wah, 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 wah. So I think it's really interesting that you got training because chaplains learn this process communication because they have to.
Yeah.
But most medical residencies don't.
Yeah. 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 It definitely is a tenet of that residency program.
Hmm.
It's something that the medical school really, values and therefore has carried over into the residencies that are associated with the medical school. But I do realize it is a very unique, experience. I also got, some time to spend on ethics committees, and again, like, learning that, being exposed to the questions and the stressors that people are coming to you with these questions. It does make a big difference, and it's something that I encourage the medical students that I work with to do is to seek out these opportunities to become a whole physician by focusing on the whole person you're seeing in front of you.
Do you find other hospitalist residencies? I mean, I assume that the experience you're talking about is not unique just because you're approachable, which you're very approachable. But there are thousands of hospitalists
There are.
in the country, in the world. Are they mostly getting this kind of exposure and training, or are they winging it, or is it something that y'all talk with each other about at hospitalist conferences?
We definitely do talk about it at hospice conferences, but it's a combination of particularly earlier in your career. you're winging it because you're trying to figure out how to be you and how to be a doctor and all of these things. And then over time, hopefully you're building those skills. But I think as medicine as a whole has really come to understand that we need to address these skill sets with people, that it's not just knowing the sodium channels and the dose of this and that makes a good physician. If you're bright enough to get to the point where someone is discussing sodium channels with you, you're likely going to get it. The thing that's going to make a difference is learning the soft skills, investing in those for yourself and then also for your patients. Because it all will also make, and if we have physicians listening, it makes a much different career for you if you can invest in those soft skills for yourself, because then you now have opportunities to try different ways of being in medicine and practicing and leading.
So, one of the things when I'm working with executives on process communication, I say, look, if you're going to deal with someone who's stressed, the very first thing you have to do
Mhm.
is address your own stress.
Yes.
You have to have something you do that charges your battery, right?
Mhm.
Because you've got to focus on their stress.
Yeah.
And you can't do that if your battery's low. It's like trying to use a phone that's in the red.
Yeah.
So,
No, it's 100% true. We do have to figure out how to take care of ourselves. I encourage people to, and it took a long time for me to understand, acknowledge who you are and what you're bringing into the room. You're not a blank slate. I used to think that I was supposed to be this blank slate of a person when I interacted with patients, that I would just not bring any of myself. But for me, that's a huge disservice to the patients because I'm bringing almost 20 years worth of experience with me, right? And so I should be able to bring my whole self. But you first acknowledge that, acknowledge what you're bringing into the room, so that, like you said, you can put down the parts that maybe aren't productive and carry along with you the parts that are going to boost you up and boost your patience.
so one of the things in this line of people being stressed and you taking care of yourself, a lot of lay people, non-doctors, we don't understand medical time, right? What
Mm.
decisions have to be made now, in the
Yeah.
next afternoon, in the next week, over the next 5 weeks? And because we don't understand medical time, we get scared
Yeah.
and we get frustrated because, like, hey, aren't we supposed to know this all right now?
Mhm.
A common example is when you get diagnosed with a solid tumor, right? The reaction is, oh my God, I have to have surgery now. I have to have chemo right now. Like, this thing is growing and it's going to kill me in 2 weeks. Eh, No, most even really aggressive solid tumors, probably not. And if it's that aggressive, they're going to tell you. But we don't know medical time. So,
Yeah.
how do you advise a patient or a caregiver to understand their actual timeline so that they can calm themselves before they make a decision if they have the time?
Yeah. So one of the first things that I would say is ask about that time frame, just outright. Is this a decision we have to have now? Is this a decision we can come back to, at the next appointment? If you are sitting with me as a hospitalist, it is likely a decision needs to be made now, right? Because we need to start making plans for treatment. We need to start calling specialists, booking ORs, like things like that, right? So if it's in the hospital, it tends to be a now decision. If you're in the clinic, ask outright. Like, is this something that we can think about and come back to at our next appointment? Or can you call me and we can come back to this conversation? But really, if you feel like a decision is literally life or death, I want you to stop and ask just that. And it's okay. It's okay to be frank with with your language. It's okay to be simple with your language. Oh my goodness, I'm I'm getting really anxious and I feel like this is a life or death situation. Is this a life or death decision we have to make? Um and if they tell you, yeah, I might tell you, yeah. But in the clinic, it probably isn't. It probably is we can talk about it in a couple days. We can talk about it at your next appointment. Go home and sit down and think about it. But even in the hospital, I will say to people, I want you to talk about it as a family, and I'll come back tomorrow. We need to have a decision tomorrow. Or I'll come back in 3 hours. We need to have a decision in 3 hours. Uh, because you're right. There is a difference between planning it's for the future and planning for what's happening now,
Mhm.
or being in a situation where you have to decide how to participate in what's happening now. And that's really what it is when it comes down to end of life discussions in the hospital. Unfortunately, sometimes it's more, how are we going to participate in this? Because this is the thing that's happening. Someone is actively passing away. How are we going to participate in this? Uh, versus, well, if we can get you home with hospice, what would that look like? How do you want to spend that time with your family? Right? Two very different conversations, but still need to be spoken about and decisions made fairly quickly.
So you brought up hospice, and I think one of the interesting things with our cultural avoidance of talking about death is sometimes we end up not having a choice because we didn't have a conversation early enough. And you had said, I really wish families would have this conversation, not the legal, what's your living will? What's your, like, okay, you should have that conversation too, but tell us the conversation you would prescribe to, well, I mean,
It's
to
probably
families that are facing a
yeah.
major medical situation.
And I would say that the more people who can participate in the conversation is the easier it gets, because then the patient with cancer, or the person with cancer, doesn't feel like this is just about me. Oh my goodness, right? Because the truth is we will all pass away. We're all going to die. Some of us will have the capability to choose how that process looks and what the experience will be for us and our loved ones. Right? And a lot of us will not get that choice. If you can have a conversation around death and dying, meaning, what would be my limit? If this thing happens to me, that is a red flag. I would not want to go any further. For instance, feeding is a big thing people talk about, right? Um, so some people will say, "Yeah, sign me up for a feeding tube." Others will say, "No, if I cannot eat, I do not want to be artificially fed." And that's my line, right? That line helps a lot. Doesn't just help me as the clinician, helps your family, because that line means they know where honoring you is. They know that they're not just acting as what I think is the best, right? Which is often the thing that happens when people get into decision making. They think, well, what do I think is best for dad? What do I think is best for my spouse? But if you say to them, like, this is my line, I would not want to ever be intubated. I do not want to be tube fed. Um, if it comes to it that my pain is so out of control that I am suffering, right? Now you're giving them clear direction and you're giving them a release. They're not making that decision. They're honoring decisions that you've made. Two very different things and two very
And
different experiences.
and I think it is worth having a transcript or writing down the notes and saying, "Look, by the way, we can change this at any time.
Yeah.
You can change your mind up until the last moment. That's, that as long as you're of sound mind, you have the opportunity to change it." And there's a couple of other things I would put at that dining room table. Um, let's talk about life after me,
Hmm.
right? And it's really hard. I don't want to imagine life after me, but
Yeah.
I also don't want their lives to stop after me because I love them and I want them to have these great big lives. And, my daughter was telling me about a friend of hers who lost her mom and got really upset 3 months later when dad started dating.
Hmm.
It's like, well, was that a conversation at the dinner table? Like, it's possible that the couple talked about this.
Yeah.
But as you said, maybe the circle was too small. I go ahead.
Yeah, I think it's what you're speaking about is so true because what she was experiencing is that guilt and that anger. And when you know you're following someone's wishes, you're honoring someone's desires for whatever it is, how you should live afterwards, they want to be treated as they're dying, that guilt, that is released. And that is a gift. That is a huge gift that you're giving to your family.
And I think people sometimes avoid it because, the family says, no, 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 you're not going to die. You're going to beat this. And I remember there was a time with a friend of mine whose husband had unfortunately advanced pancreatic. And,
Um,
she and I were just sitting outside and I said, have you talked to him about what he wants and what he wants for you?
Yeah.
And she said, well, I'm hoping he's going to get better. I said, well, the two aren't mutually exclusive. You're not giving up on him by saying, I want you to be able to talk to me about what you want. And if there's things you want from me, I want you to tell me. I think I told you, Monique, one of the most profound expressions of love I've ever witnessed was when my grandmother was dying. And we were all like, no, you're not going to die. She even gave me her tennis racket. And I said, Grandma, this is your racket. What about when you want to play? And she said, oh, honey, if I can play tennis again, your grandfather's buying me a new racket. And I said, okay. But what was so deep, they'd been married for 50 years. They married when she was 19 and he was 21, right? Babies.
mhm,
And she looked at him and she told us that she had done this. And she said, you are no good alone. It's not good for you. It's
mhm.
not what I want for you. So you definitely should date. In fact, this is the woman you should go date and be with. And he says, well, she's got a fella. And my grandma's like, yeah, she won't. Just give it time. Um, but she's like, I want you to date. I want you to have companionship. You need it. And it is not a sign of your love for me that within weeks or months of my dying, you are dating. That's because you don't want to be alone and I don't want you alone.
Yeah.
But you're right. Like the whole family, when he started dating, we were like, good idea. Grandma was right. You know,
Yeah.
this was awful. And yet she's gone
Yeah.
and he's not.
It's very interesting what you said, that there's no less love for me. And I find sometimes that we think that loving someone means keeping them around. In fact, this happened to me literally yesterday. I had a patient who's like well into her 90s, very complicated medical history, but still had a full code status, meaning if something happened, heart stop, she would get CPR, electric shocks, medication, intubation in the ICU at 90 odd, right? Like well into her 90s. And she wasn't going to die in this hospital stay. But I was like, "Oh, we should address this in general," right? She also had touch of dementia, some other things. And I spoke to her adult child who was a decision maker, and I said, "Is this really what you would want done?" And the answer to me was, "Yes, I want all that done. I love my mother." And I knew we weren't gonna get anywhere else in the conversation. Again, I'm an interloper. I'm here for a short amount of time. She was actually ready to go home. But I did put it in my note for the primary care to continue talking to them. But but that was the answer, that I love you, so I keep you around. I love you, so I'm gonna continue this thing that maybe is hurting you, is hurting me, is hurting us as a family. And then when you're gone, I'm gonna continue to hurt because I loved you. And I I would encourage us to try and think of love very differently. You don't love doesn't have to mean suffering.
Well, sometimes the most loving thing you can do is say, I don't want you to suffer anymore. Like there is a point, I'm sure you see it all the time, where recovery is not going to happen.
Yeah.
Like things are shutting down and, you know, it's or maybe even before things are shutting down, but there comes a point where for all of us, recovery is not going to happen. And we have to find out a way to talk about that with our loved ones. I kind of think it's better to talk about it way before that's a thing. Like talk
100%.
about it openly when everyone's healthy and we can just say like, "Hey, this is
Yeah.
what I'd want. This is, and I reserve
Yeah.
the right to change my mind."
Yeah, and I agree with you because if I'm looking at you to have this conversation, it's because there's not a lot of decisions left, right? And I mentioned earlier that there are some decisions where we're going to decide how this is going to look, and there's some decisions that we're going to decide how we're going to participate in this, right? And oftentimes, if I know a patient is really unfortunately dying and this isn't going well, and the conversation is just hard and no one's not going anywhere, I will say the last thing I want is for them to die and you're the only one who's surprised. This is why I'm here, is because this is the thing that's happening. And how are we going to support them through this and support you, right? And believe it or not, patients know. They know, people know when it's not just that they've had enough and they're in too much pain and they're suffering. People know. We all have an inner thing in us that knows when our time is there, right? And they're not surprised that they're going to pass away. How are we supporting their family members? And so that's why, I'm here to have this conversation. It's an icky conversation. It's uncomfortable. You're not going to want to do it again, but do it in bite-sized pieces, little at a time, over and over until it's no longer uncomfortable, right? And when I say over and over, don't do what my parents do, which is, well, you know what I want. That's not an answer. Well, you understand. No, tell me the words. Make the words come out of your mouth so that I really can know what you want.
Well, and the reason I said write it down is and I have siblings or I have
Yeah.
other family members, and I want to be able to say, this is what you want. And I think they're just crucial conversations, and nobody wants to have them. I mean, I love the idea of do it in bite-sized chunks, right?
Yeah.
Like, do it, it's just you should update your will. You should update how you wanna live, because I think how you die is part of how you live.
Yeah.
And
Yeah.
so, all right. When a cancer patient tells you, "I need to stop, and
Mhm.
my family isn't ready for that." You've
Yeah.
been that bridge. What do you wish the family members understood what their loved ones are really asking for when they're saying, "I'm done. I can't anymore."
The number one thing I want family members to understand is they're not giving up. They're not admitting defeat. The language we use around cancer is a language of aggression. You're going to fight it. I'm going to beat it. Right? She's a winner. She she isn't going to lose to cancer because this isn't a competition between your loved one and out of control lymphocytes, right? This is about somebody's humanity and how they're experiencing their body and how they want to be treated towards the end of their life. And that's the number one thing I want families to understand. They're not giving up because that language is is a language of guilt. And I hear it a lot. "Oh, don't give up, mom. There's no white flag," right? Because it's not a competition. we now have therapies that allow patients to live many years longer, right? But all things in humanity end with death, right? It used to be that AIDS was a death sentence. Now patients with AIDS are dying from heart attacks in their 70s and 80s, right? But they're still dying. We're all going to get to that point, and I want you to love on them at that point rather than impart your feelings of, like, expectation and causing guilt.
Well, it's interesting because I wonder if we can give people some language there, or maybe I should have a chaplain on, because, what we're really saying is, I love you and I can't imagine my life without you. And see, I get choked up thinking about it. Both my
Mm.
parents are still alive. It's really hard, but that's what you're really saying. So say it.
Yes. Yes, say that. "I'm gonna miss you.
Right. Sorry.
Thank you for loving me,
Thank you for everything. Thank you for
for
the daily phone
everything.
calls. Thank you. Thank you for the traditions.
Thank you for teaching me how to be a mother,
Right.
teaching me how to be a daughter, teaching me how to be in this world, and now
Exactly.
I'm going to be with you
Right.
towards the end of this."
That's right.
But I really want people to put away that language of giving up.
Well, that's why I was suggesting a replacement,
Yeah.
right? A replacement for that, because people say that because they think that's the right thing to say, because they think what they're saying is, I don't want to lose you.
Mhm.
So say, I don't want to lose you. And, I remember I was very pregnant with my second kid, and my husband's grandfather was 87 and developed pancreatitis, very severe.
Mhm.
And I assume a hospitalist, someone said, I don't think he's going to recover. And I looked at my husband. I said, you need to go across the country. And he said, but you're pregnant. I said, I'm not having this baby anytime soon. You need to go across the country. Because why would you want to wait till he's gone to tell him everything?
Mhm. Yeah.
And he goes, what if he doesn't die? I said, then tell him twice. Who cares?
Yep. You get a good trip. Tell
Right.
them
I,
twice.
I guarantee telling somebody what they've meant to you is a conversation that never gets old. You can have it over and over and over again. So, I think this has been wonderful. I would love to go into the lightning round. These are
Yeah.
quick ones. I'm going to give you 5 things. You answer real quick, and hopefully we can have some fun. Ready?
Yeah.
All right.
Alright.
Complete this sentence. The funniest thing people think a hospitalist is.
Very on brand. A hospice worker. So I I will walk in and say, "I am your hospitalist," and then be like, "Your hospice?" And they're there for, like, a foot rash or something. I'm like, "No, no, 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 no." And believe it or not, that one gets,
That's
mixed
great.
up.
You
Very
could
on
just
brand for the topic.
you could just walk in wearing all black and a side like I'm the hot. Yeah,
Oh,
no,
yeah.
don't do that. One thing every cancer patient should bring to the hospital that they probably forgot is.
Your journal. You're gonna spend some time by yourself. Write it all down. Write down your feelings, write down your thoughts, if it's something that just brings you solace, that's great, but you can also be something that can bring your family member solace a little later if they get to a chance to look at it if you're not there.
That's beautiful. The single hardest sentence you've had to translate from a patient to their family was.
This one got me, Joel, I'm not gonna lie. This is maybe where I get choked up. Um, I had a patient who was a pretty significantly developmentally delayed, and so was not making their own decisions, but was passing away. And, their sibling, who's also their age group, had a real hard time with it. And this person said, "I'm sorry for whatever I did. Can you please let me die?"
Oh, oh,
And he saw his suffering as a punishment that was being metered out, and that changed the entire this is where I'm getting mi like, it changed the entire tenor of the conversation because it brought to his adult sibling something that I couldn't through all of my conversations, but when he said, "I'm sorry for whatever I did," um, and that was a hard one for me. It was a hard one for everyone in the room, and that was years ago, and it's still when I read that question, it hit me.
Yeah,
That was
but
the hardest one.
because we all have these stories, these narratives. Yes, they were both. We're making each other cry, Money. My God.
Mm,
Um, it's because we're real. We're talking about the
yeah,
real stuff, and it's not all happy. I mean, I looked when you're talking about the warrior. I'm like kicking cancer's ass. I'm playing into the warrior thing, but that's not kind of what I meant with kicking cancer's ass. I mean, like you do it your way,
mhm,
the whole way.
yeah,
You're not a passenger, and so you know nobody wants someone they love to be tortured and suffer. And we have to kind of I would hate that someone I love felt like that. I can
yeah,
get why, like, what have I done that's so terrible that you would keep doing what
to
you
me.
would want me to keep doing this?
And that's where I say it's not about doing what you think is best because that's where the sibling got into it. The sibling was doing what they thought was the best thing,
Right.
right? Your role as somebody's healthcare proxy is not a decision maker, two different things. A decision maker makes decisions from them. A proxy is someone who's acting as if. They are you. And then you've
Interesting.
had the conversation, you've written it down, you've communicated, right? Now you've given them that tool. Now, this gentleman was in a different situation because his cognitive situation was
Sure.
very delayed. And so he had a decision maker who was doing what they thought was best when maybe the conversation should have been between the two of them to understand what he wanted, right? But that's a totally different conversation. But when you're when you have given your family members, your loved ones, your support system, your voice, you're letting them honor you and acting as if they are you, which is what a healthcare proxy is, which is what most cancer patients are able to do, to say, "I want this person to be my proxy."
Mhm.
And I want people, if you're given that honor to be a proxy, lean into that word, proxy. You are there as if you are the person. You are not there to make what you think is the right decision. You are there to honor the decisions they've already made.
Mhm. Which is why
And
we have to have the conversation at the dining room table
exactly.
long in advance.
Long in advance.
All right. If you could change one thing about how doctors deliver life-changing diagnoses or news, because sometimes it's not the diagnosis, it's this is where we are, what would it be?
I wish doctors would realize how much of the information we give is life-changing. I think we give so much information so often that it becomes very, mundane to us,
So
right? And so doing something like diagnosing someone with diabetes is something that I may do 2, 3 times in a day.
wow.
But one patient is getting diagnosed with diabetes for the first time, one time in their life, and that is a life-changing diagnosis.
Mhm.
Telling somebody that, like, mom can't live alone anymore. Again, something I may do 4 or 5 times in a week. But what have I done? I've changed a whole financial picture for a family, a whole family dynamic, a whole living situation. Like, there's so much information that we give that we see as mundane that truly is life-changing for
Mhm.
people. And I wish that was the first thing that we as physicians did, was slow down and realize it's not mundane information.
Well,
Um,
and the protection that doctors do for their own health, their own mental health of, "I have to keep a clinical distance." It kind of makes the communication hard because what someone's looking for in that is compassion, empathy.
yeah, it's a hard career to figure out your line. But that line gets redrawn so many times because you change so many times,
Sure.
right? So, like, I'm a daddy's girl. And if there is one conversation that's gonna leave me in pieces in a hallway, it's having conversation with a daughter and her father, right?
Yeah.
About losing her father. I'm gonna be in the hallway and I'm gonna be in pieces. And as a younger physician, wall up because I didn't know how to protect myself in other ways. But now I've understood that maybe this is a place that I can be softer because I've put the wall up in other ways, right?
Well, and it isn't actually happening to you. You're
Yeah.
there to help somebody else. And with the empathy of you do know how they feel,
Mhm.
but you're not there to tell them what to feel. You're just there to help them feel what they feel.
Yes.
And I
Mm.
think we all overestimate how long bad feelings last. And so we're
Mm.
scared of them. And there's tons of research on mental health that are like, other than clinical depression, and like, I'm not talking about actual disorders.
Yeah.
We don't, we can't stay mad, sad, or frustrated for actual long periods of time. It just doesn't
Mm.
last. So we're going to feel it and then it's going to pass. And then we shouldn't feel guilty that it passed. We're wired for
Yeah.
this. So you can be with us when we feel it and know it's going to pass.
Yeah. Yeah. And
Uh,
and I encourage younger physicians to understand that you're gonna redraw those lines several times. And that's okay. It's not a sign of having done it wrong. It's a sign of learning how you're gonna continue to do it in the future.
so I was just thinking about, I'm talking with a lot of people in genetics because cancer and genetics, particularly early onset, it's a big opportunity of discovery and science, and it's great. But a life changing, non diagnosis, but life changing news is you have a genetic mutation for
Mhm.
blah, 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 blah. And it means this kind of screening or these kinds of options or what have you. And a bunch of people I was talking to, world renowned oncologists and surgeons, were hesitant on recommending genetic testing because how will somebody feel if they know they have a genetic mutation? Well,
Yeah.
turns out City of Hope has actually done research on this. And we're going to have Kathleen Blazer on. But turns out it's just what we said. It's shocking and upsetting at the moment. And then you recover and figure out how you're going to
Move
live your
on.
life with this new piece of information.
Yeah.
And someone said to her, "Oh, but our culture doesn't recover like that. Our culture, women wouldn't want to know because they might have to do something that makes them
Hmm.
less sensual." And then they did the research, and the women said, "Of course I want to know because if I can know, I can be here for my children and grandchildren. Take
That's
whatever piece of me you want."
that's very interesting. That's interesting, particularly because in this country, like, even in the 70s, 60s, 70s, women were not told diagnoses for
Crazy,
themselves, you
crazy.
know? And so, yeah, this idea that particularly women are not tough enough, like, I don't know. You
You've
seem
had
pretty tough to me, Joelle. I feel
You ever
like
watch childbirth people? Let's get
I
real. We're tough.
know,
We're
right?
plenty tough.
You're probably tough.
You don't have to be unemotional to be strong. I actually, my dad used to tell me, like, Joe, a willow is a stronger tree. It stands up in a storm
Because
more
it can move.
effectively than an oak because
Mm,
it
it can move.
sways.
Yeah.
All right. What is your advice for someone looking to kick cancer's ass?
The number one thing I would say is you are not cancer, right? Like, cancer does not have you, right? You are so much more. You were more before, you're gonna be more during, and you're gonna be more after. And so continue to lean into all those parts of you. Um, Suleika Jawad, I believe her name is, and the author, the Girl Interrupted. I'm sorry, Life Interrupted. I loved her book because she wrote about all the youthful things that cancer patients who were young were still doing, right? They,
Mhm.
yes, they had cancer, but they were still having, you know, hooking up and having sex and doing all the things 20-year-olds do,
'Cause they're
right?
20.
Because they're 20. Just because they have cancer doesn't mean they're still not 20, right? Going on road trips. Um, Continue to be a whole person of you. It aches me when I see people for whom cancer has become the only thing. Um, and I understand why. It is a huge thing, and it is scary, and it's gonna take up your time, your body, your finances, your logistics. But this is why I say bring your journal. There's so much more to you. You know, do the other things. Don't give up the other parts of you.
I agree. I have a whole concept of happiness tripwires, which is about, like, every day there can be something that makes you smile, and that is good. You don't have to be sad and mad and sick all the time. You can have a moment.
Yeah.
All right. Monique, where can listeners find you, your book, your podcast?
Yeah, so you can find my podcast where you find podcasts like Apple Podcasts, Spotify, places like that. And then you can find the book, which is also named Prescription for Admission. Some people say I'm really good with branding. I say that I just lack creativity and I just kept going with the same name. But you can find that wherever you buy books, which would be like on barnesandnobles.com or amazon.com. And you can also visit my website, which is Dr. Monique Nugent, drmoniquenugent.com, where you can find my podcasts, other podcasts I've been on, join my mailing list, get my blogs. I also have some other things that you can get there, and then you can also, purchase the book. And if you're looking for bulk orders, because I do get groups that like doing it, reach out directly.
Awesome. Well, it has been, again, such a pleasure to talk with you.
I know this was so much fun, Joelle. Thank you so much, and I'm so excited for the dual release. This is
I
going to be
know.
great.
It's going to be awesome. So, for everyone listening, remember, you don't get to pick your pitch, but you do get to control your swing. I'm Joelle Kaufman. You can catch Monique's interview of me on Prescription for Admission the same week you're hearing this podcast,
Yeah.
wherever you get podcasts. And please, if you've liked this episode, subscribe and then share it. It's a great way to start a conversation that can unlock love and relationship and just connection at such a deeper level. See you next week. Until then, keep kicking cancer's ass.